Hi everybody. I'm going to attempt to do my first video online PowerPoint presentation lecture. Okay. So I'm going to be scrolling through the PowerPoints and hopefully they record properly. If not, I'll have to spend another 15 or 20 minutes re-recording them. Remember, like I said in the first the intro video, that I'm going to make the segments shorter, like 15, 20 minutes, somewhere around there. That way you can watch them at your convenience and fit them into your schedule better. However, just make sure that you have the assignment completed by the next class, and we'll be fine. Okay, and I have that posted on Moodle, your assignment. So, all right, we're going to start here with my favorite personality disorders. Okay, let's see. All right. So an overview of personality disorders. They're put into three categories or clusters. Okay, you have cluster A, B, and C. Cluster A entails paranoid, schizoid, and schizotypal. And then cluster B are the ones I am intrigued by that I discuss in class. I've brought them up a few times. That they are okay, so you have antisocial, borderline, histrionic, and narcissistic. And then you have cluster C, which are avoidant, dependent, and obsessive compulsive. Now keep in mind that the obsessive compulsive personality disorder is not the same as the obsessive compulsive disorder we discussed a few weeks ago in class. They're different. I'll explain why when we get there, but just keep that in mind that it is not the same. Okay. All right. So now, okay, so you have the three clusters. The cluster A are all based around odd or eccentric traits. Okay, and then you have cluster B, which are all dramatic, emotional, or erratic type. And then you have C. So cluster C's are all based around being fearful or anxious. All right. Okay, so personality disorders, a persistent pattern of emotions, cognitions, and behaviors that result in enduring emotional distress for the person affected and or others in their lives as well. So, uh, someone that is involved in your life, especially somebody that's significantly involved, like, your parents or siblings or a spouse, you know, they're going to be affected by your behavior, right? Even just, distant people, like, an acquaintance may also, you know, be affected by the way you're behaving, right? By your disorder. It affects other people as well. And it causes you difficulties at work, in your interpersonal relationships, as well as causing others distress. Sometimes it may cause others more distress than you because you don't see you as a problem, so your actions aren't bothering you, but they're affecting other people. All right. Um, okay. There we go. I really hope this is recording so I don't have to do this again. Okay, so personality disorders are enduring, inflexible predispositions. They're maladaptive, they cause distress or impairment, just like all the rest of the disorders, right, that we talk about. There's a high comorbidity rate with personality disorders. So, as we've discussed in class, people that are often diagnosed with depression also, have a diagnosis of anxiety at times. It's comorbid. Personality disorders are highly comorbid. Okay, so you should assume that when they have a personality disorder, that it's most likely that they have another personality disorder or another disorder of some sort, whether it's a mood disorder or whatnot. Okay. Um, so generally, there's a very poor prognosis with personality disorders. They are egocentric. What that means is they're perceived by the individual as congruent with their self concept, meaning the same as their characteristics. Okay. So um, it's not really seen as a problem to the individual with the disorder, right? They think, well, that's just my personality. That's just me. That's not a disorder. And so they think the problem isn't them, it's the rest of the world. And as you can imagine, that causes a lot of difficulty in many areas of their life, but also for the therapist who's trying to work with them. If they don't want to be there and they don't think they have a problem, it's really difficult to help that person. And many of the people with personality disorders are mandated into treatment. So that means, they're not there because they brought themselves in or because they want to better themselves. They're there because they have to be there. Maybe they got in trouble with the law, and, the part of their treatment is to have to go to therapy. So how much do you think they're going to get out of that when they don't think they have an issue and they don't want to be there, right? So it's very hard to work with them. Okay, and we know that there's 3 clusters. Okay, so I briefly went over this as well in class. So categorical and dimensional models, kind versus degree. So the personality disorders have traditionally been assigned, an all or none, um, into all or none categories. So if you met a certain amount of criteria, then you were categorized as such and such. The DSM-5 did retain the categorical diagnosis, but they also introduced a dimensional model of personality disorders, which is, individuals are rated on the degree to which they exhibit various personality traits. Okay, so they can either maybe, they're measured as having a high degree of a trait, or some may have a lower degree. So they're also measured on that as well as categories. Okay. Um, all right. So this, you don't really, I'm not going to go through them, but you should go through the personality disorders on your own. I've done this, like print, this out and maybe put it in your textbook. It's a very handy. It's, gives you a brief description of the personality disorders. So, just because I'm not going to go through them step by step, we're going through them in more depth now, but, that's something you should read through on your own. Okay. Prevalence of personality disorders. They affect about 1% of the general population. That, I personally think that is a significant understatement. And, there is many more than 1%, but researchers only have so much to go on, right? The data that we have out there is the people that we know of. What about all the people we don't know of, right? And since we know personality disordered individuals don't think they have a problem, they've never entered therapy. So how do researchers and therapists and people in the profession even know who they are or where they are? We don't know these people exist because they haven't, brought themselves into awareness, so to speak. But we know, and as we go through these, you're going to say, oh, yeah, I know people like that. Oh, yes, I know someone like that. Oh, gee. And you'll see that there are many more. Okay, so origins and course of personality disorders. PDs are thought to begin in childhood, and they tend to run a chronic course if untreated, right? They're not going to go away on their own. They may even become worse on, without being treated. And so it will last a lifetime and never go away if it's going to, if no one goes in to have, to get help if it goes untreated, it's going to run a chronic course. Okay, and so it may transition into another personality disorder. This is just the prevalence rate. That's another thing you can go through on your own. Okay, so gender distribution and gender bias in diagnosis. Men are more often shown with traits of aggression and detachment, right? And they are more often labeled as antisocial. Women often show submission and insecurity. Women are more often labeled as histrionic. Uh, Keep in mind that just because there's a gender difference or a bias in research doesn't mean that the opposite sex doesn't also um, entail these, traits and should, many should be like. In fact, I remember bringing this up in class. We were talking about the Jodi Arias case, and I said I was watching that. I was so intrigued by that. But I watched that religiously on television, that case. And the moment I saw her, I said, wow, she's definitely antisocial. And I knew, excuse me, women were not, um, many women aren't diagnosed with antisocial, but it doesn't mean that they aren't. It just means they haven't been researched, right? Because researchers only have so much data. They have the information that we give them. And so if women are already biased as that, they're going to have that category that they have to work with. So, they're not really working outside the box, I guess you can say. So just know that just because there's a gender bias, you know, there are also many women that probably should be labeled antisocial, but they are considered histrionic. So histrionic is more of the woman's antisocial, and you know, male histrionic is antisocial, women's antisocial is histrionic. That makes sense. Okay, so comorbidity is the rule, not the exception. So just assume that everybody with a personality disorder also has another personality disorder or another disorder of some sort, whether it's a mood disorder, but there's always another. Um, so that's the rule, not the exception. So just assume that. Many times you'll find in therapy that as you're working with the client, you'll be discovering, they may have come in because they have high anxiety. And when you start working with them, you realize, wow, they have a personality disorder, which is, the foundation of what's bringing about maybe their anxiety or another, disorder. But you'll see that more often than not, okay? All right, let's see. So this is just another chart. It's the comorbidity of PDs. That's, go through these, even though I'm not going to review them with you. They're on the PowerPoint for you to go through. Okay, so PDs under study. Sadistic, they enjoy inflicting pain. Remember how I mentioned in class a few weeks ago, sadism is when they enjoy inflicting pain. A masochist is the one that enjoy receiving pain. Okay, so then, and passive aggressive is defiant. They undermine authority. So further research is needed, but I wanted to put them in here anyway. Okay, so the DSM-5 with personality disorders, as we said, they're clustered into A, B, and C. And, we kind of reviewed this. I just put it in here to keep it in, but I put them together. So cluster A is odd or eccentric, which involves paranoid, schizoid, and schizotypal. Cluster B is dramatic or erratic, which is antisocial, borderline, histrionic, and narcissistic. And then cluster C, which is anxious or fearful, and avoidant, dependent, obsessive compulsive personality disorders. Okay? Wow, that went fast. All right, that's my alarm. Okay, so I'm gonna just do a couple more slides and then stop. Okay. So, pervasive and unjustified mistrust and suspicion. These are paranoid personality disorders, right? So, they consist of pervasive and unjustified mistrust and suspicion. There's few, people with paranoid personality disorder have very few meaningful relationships, and they're very sensitive to criticism, and they have a poor quality of life. All right. Now this is another I kept in here for you to read through. It's the criteria for paranoid PD. Okay. Paranoid PD, the causes are not well understood. They may involve early learning that people in the world are dangerous and deceptive. Cultural factors, more often found in people with experiences that lead to mistrust of others. So, prisoners, refugees, people with hearing impairments, older adults, they all, you know, they're more susceptible to paranoid personality disorder, right? So, and that makes sense. Someone in prison, they're surrounded by people that they have to be aware of, right? They're hyper vigilant, always, keeping their eyes open. That makes sense. Uh, Refugees, same thing. You know, they have to be aware. They're worried about what they had done, probably, and they're living somewhere else now, and they have to keep their eyes out or open and keep a watch out. Older adults, they are not as strong as they used to be. They're not as witty as they used to be. So they're susceptible. People with hearing impairments, if you can't hear very well, you're going to be hypervigilant, right? I remember being in a bank and there were probably about 15 people in line. I was the only one. I was like everybody else was foreigners. I wasn't. And that made me uncomfortable in a way that because I didn't understand anyone's language, and they were all talking, I'm like, I wonder what they're saying. So like I was almost, a slight degree, but I was a little paranoid, wondering, are they talking about me? There's like a whole section. And there are things, that would make you more susceptible than others. And so, the cultural factors um, lead to mistrust. Okay. Um, so treatment options. Few people with paranoid personality disorders seek professional help on their own. The treatment focuses on developing trust, right? Cognitive therapy to counter negative thinking. So, if someone came in, and told me, and I kind of figured out, or they came right out and told me that they do not trust anyone, I would sit there and do cognitive therapy. I would try to help them think about the people in their lives that are trustworthy, that they can trust, that have never given them a reason to doubt them, right? And these are the things you want to try to do to help them. Okay, but there's a lack of good outcome studies. And many is because they don't come in treatment to begin with. So researchers only have so much, you know, to be able to really study because there's not a whole lot of cases. That makes sense. All right. Okay, we'll do this one on the next clip. I'm going to pause right here.